Dr. Vaibhav Kumar Jain. Yes. So, we'll be talking about on early phacoemulsification and acute primary angle closure, the efficacy and the challenges.
Good morning to all of you. Today my topic is early phacoemulsification in acute primary angle closure, their efficacy and challenges. So coming to the introduction, the India is having significant number of patients with primary angle closure glaucoma, which almost forms the half of the adult primary glaucoma in various studies. So acute angle closure is relatively rare as compared to chronic PACG or subacute primary angle closure, but it poses an ocular emergency because it is accompanied by sudden rise of intraocular pressure and patient experience severe headache, nausea, vomiting, redness and watering. So laser peripheral iodotomy is the current standard treatment of these patients because it breaks the attack. But laser peripheral iodotomy is relatively it's not without the any adverse effect. It is relatively difficult to perform if the patient present with the acute primary angle closure attack. Because of thickened iris, we need to deliver more energy with the Nd:YAG laser. Pupil is also mid dilated. It can unable to get the pilocarpinize that pupil. Lot of inflammation may be there in these eyes, and lot of pigment shedding occurs during doing the peripheral iodotomy. And also greater endothelial cell loss occurs because of the shallower anterior chamber or almost flat anterior chamber. Also cataract development enhanced by doing these laser peripheral iodotomy in these patients. There is another option of surgical PI in these patients. So if you are unable to perform the laser PI, we can consider doing surgical PI, but it is relatively less preferred due to the invasiveness of procedure. So in one study, the surgical PI was associated with more surgical re-intervention as compared to phacoemulsification in these patients. Now coming to Eagle trial, that is a multi-center RCT, and it is done in the 5 countries and 419 participants. So they showed that the clear lens extraction was more efficacious and cost effective as compared to standard LPI. And there were further reduced need of further glaucoma surgery in clear lens extraction group. Also, there was reduced need of anti-glaucoma medication in clear lens extraction group. So there are certain RCTs which compared the phaco versus laser peripheral iodotomy in acute PAC. There is relatively less RCT, only 4 I have found. So they showed that the phaco is having better IOP control and fewer anti-glaucoma medication needed for post-op. Also, after doing phaco, the anterior chamber is deep, and also it improves the visual acuity. Now coming to effect of phacoemulsification on IOP, there is a report of American Academy of Ophthalmology, and there is 71% reduction from the presenting IOP after doing phacoemulsification in these procedures. And these patients rarely require long-term medication to control the intraocular pressure. Now, how safe is lens extraction in acute PAC? So there are certain challenges in doing phacoemulsification in these patients. Like capsular access is a relatively difficult part because you don't have a space. You have shallow to almost flat AC. So you need to do the proper AC reformation before attempting the capsular access. Chances of Descemet membrane detachment is also there. These pupils are not able to dilate properly, and we have to control the intraocular pressure by giving pre-op mannitol, and medical control of IOP is must before. Chances of PCR is also high in these patients. So there are certain fewer surgical trips to avoid the complication. First of all, surgical expertise in phaco is needed before attempting these cases in acute PAC. Ample use of high density viscosurgical devices are must, and use of pre-op mannitol is also must, and a good hydrodelineation is also must because these cataracts are mostly grade 1 to 2 nuclear sclerosis. They come with the just hydrodelineation, and we can take it out with the phacoemulsification. Now we have done a study in our center. So we have recruited till now 14 patients of acute PAC. This was a prospective non-comparative interventional series. So we took patients of 40 years or more and presented with acute primary angle closure of typical clinical symptoms. The angles were occludable, and the outcome measures were best corrected visual acuity (IOP), number of quadrant in which we are able to see the PTM on gonioscopy, and the number of AGM. The follow-up was relatively short. So this was the baseline data. We can see the pre-op IOP was 38 millimeter mercury. In these patients, lens thickness was also high, around 4.9 millimeter, and none of mostly occludable angles. So only 0.13 mean value is the number of quadrant in which the PTM was visible. So we can see the IOP trend after surgery. Dramatically, IOP has come down after phacoemulsification, and mostly I have experienced the patients are without any anti-glaucoma medication after surgery. And also the number of anti-glaucoma medication, mean number was 4.2 and has come down to 4.4. And BCVA has significantly improved after surgery. So these are the literature which have mostly few studies are here in the literature. And we noticed one Descemet membrane detachment in one patient that was resolved with the further intracranial air bubble injection. No other significant complication was noticed. So lens extraction in acute PAC is a challenging task. The surgery should be performed under the pre-operative mannitol before the dilatation of pupil, and phacoemulsification should be performed using high density viscoelastic material like sodium hyaluronate, which reduces the chances of capsulorhexis runaway. We report the significant improvement of BCVA, well controlled IOP, and reduction in the number of AGM and number of quadrant in which PTM was visible on the gonioscopy. So coming to conclusion, the early phacoemulsification appear as an effective option for medically controlled acute angle closure attack associated with cataracts, grade 1 to 2 cataract. Thank you so much.
Thank you, sir. So this is in the study, can I just clarify, this is without a laser PI when the patient is coming?
Yeah, without laser PI we have performed straight away phacoemulsification in these patients.
The patient
And I have
one day control the pressure, and after how many days cataracts are
within a week.
Within a week.
We have admitted the patient, and patient was on mannitol or everything, glycerol.
Steroid also?
Not steroid. So we have found the significantly pressure has dramatically come down to 14, 15 without any anti-glaucoma medication from first post-op. So we are, yes sir, glycerol. Yeah. Yes, sir, glycerol was also given, and before surgery, the routine pre-operative mannitol was given in these patients. We are recruiting more patients in this study, so we are trying to publish it in some good journal. Sir, within a week. Mannitol 300 ml, sir. In 20 minutes, yeah. Yes, 20 minutes.
So the mannitol is given even when the patients come with the attack, and then once before surgery?
Yeah.
Like, is the pressure measured again before surgery?
Before surgery, we generally measure the pressure. It must come down below 30 millimeter of mercury. So before surgery also we measure the pressure, but next post-op day, in all cases we get the good result. No sir, till now not, but we experience the difficulty of doing phacoemulsification in normal routine cases versus acute attack. It was relatively difficult to do.
Actually, these patients have angle closure attack secondary to a high lens vault.
Yes.
That's why. So then there's some difficulty in the CCC.
Yeah, CCC was difficult, and also there are
It can run out.
risk of runaway is very high in these patients. But results, because we also experience the difficulty in laser PI also. Sometimes we don't get lot of pigment shedding, then patient will develop cataract after 3 months or 4 months. Sir, earlier we used to do laser PI in these patients earlier, but right now we are just doing the phacoemulsification in these patients. Thank you.
Thank you.
Ma'am, yeah, surgical tip we can use the AC maintainer, though we have not used it, but we can for deep anterior chamber we can use the AC maintainer also.